I'm Susanna Proudman. I'm a rheumatologist at the Royal Adelaide Hospital in South Australia. And these are my disclosures. Systemic sclerosis, also known as scleroderma, is characterised by three main pathological processes: inflammation and vasculopathy, which culminate in interstitial fibrosis due to the excess production of type 1 collagen, initially in the skin, but also often in the interstitium and blood vessels of internal organs. This talk will focus on the lung manifestations of scleroderma, particularly pulmonary arterial hypertension, but I will touch on interstitial lung disease when it coexists with PAH. Broadly speaking, two subtypes of scleroderma, diffuse and limited, are described based on the extent of skin involvement, although they tend to have different clinical phenotypes, autoantibody profiles, rates of progression, and survival rates. It is important to note that pulmonary arterial hypertension occurs in 10% of all patients, regardless of subtype. Pulmonary arterial hypertension can be classified as Group 1 or precapillary pulmonary hypertension, as it is a vasculopathy affecting the small pulmonary arteries. It leads to increased pulmonary vascular resistance, reduced exercise tolerance, and eventually right heart failure and death. The expansion in vasodilator therapies in recent years has improved the quality of life and survival of patients with scleroderma PAH, but the morbidity and mortality remain high. Pulmonary arterial hypertension is not the only cause of increased pulmonary artery pressure in scleroderma. In fact, delineation of the predominant pathology can be challenging. In addition to Group 1 PAH, pulmonary hypertension due to left heart disease, the most common cause of pulmonary hypertension in the general population, may occur as a result of myocardial involvement by scleroderma-related inflammation and fibrosis. Other causes of pulmonary hypertension include hypoxemic lung disease, usually interstitial lung disease, and chronic thromboembolic pulmonary hypertension, noting, of course, that scleroderma patients have an increased prevalence of anticardiolipin antibodies. So ventilation perfusion scanning is indicated if pulmonary hypertension is suspected in these patients. Pulmonary veno-occlusive disease is a rare and particularly devastating form of pulmonary hypertension. It is often difficult to diagnose ante-mortem, has no known treatment apart from lung transplantation, as it is uniformly fatal. Scleroderma lung disease, defined collectively as PAH, interstitial lung disease, and coexistent PAH and ILD, is now the most common cause of death in patients with scleroderma, contributing to nearly 75% of deaths due to scleroderma in this Australian cohort. The survival in these Australian scleroderma patients with newly diagnosed PAH treated in the modern era was still poor, with a 3-year survival rate of 62% and 15 years of life lost, which remains worse than that for idiopathic PAH. Survival can be improved with formal screening programs leading to early detection and treatment. These patients had a better 3-year survival of nearly 95% compared with 43%, and a mean time to death of 4.7 compared with 2.3 years. When it comes to treatment, there are 3 key pathways involved in the pathogenesis of PAH which can be targeted. The vasoconstrictive and proliferative effects of increased endothelin-1 can be inhibited by endothelin receptor antagonists such as macitentan. The reduced nitric oxide-induced vasodilatation can be reversed by phosphodiesterase 5 inhibitors such as sildenafil, or the soluble guanylate cyclase stimulator riociguate. The reduced prostacyclins can be counteracted with prostacyclin analogues such as epoprostenol and selexipag. Epidemiological data indicate that combination therapy with vasodilators from more than one class offer a survival advantage over monotherapy, as shown here. In this study, most patients on combination therapy were receiving dual therapy with an ERA and a PDE5 inhibitor. Their 3-year survival rate was 83% compared with 50%, and their mean time to death was 4.9 compared with 3.5 years. In most cases, the combination therapy was commenced at as a step-up approach and not at the outset. The AMBITION trial was the first trial of upfront combination therapy. It compared the ERA ambrisentan and the PDE5 inhibitor tadalafil with first-line monotherapy with either drug. The primary outcome of the trial was reached, as combination therapy reduced the risk of clinical failure events versus the pooled monotherapy arms by 50%, with the main treatment effect being driven by reduced hospitalizations. A similar outcome was achieved in the post-hoc analysis of the data for patients with connective tissue disease PAH in the upper panel and scleroderma PAH specifically in the lower panel. Similar results were found in the Optima trial, which was initial double combination therapy with macitentan and tadalafil in newly diagnosed treatment-naive patients with pulmonary arterial hypertension. The most effective therapy for scleroderma PAH remains epoprostenol, which counteracts the reduction in prostacyclin synthase. It is a prostacyclin analogue which is given by continuous intravenous infusion, so it's generally reserved for patients with severe functional limitation, especially class 4, when it is often given as triple therapy with an ERA and a PDE5 inhibitor. More recently, the non-prostanoid prostacyclin agonist selexipag has become available, and therefore, being an oral option, it is now possible to give oral triple therapy. These two placebo-controlled studies of selexipag included patients with scleroderma PAH. In the Griffin trial, 80% of patients were on background therapy, so the addition of selexipag constituted step-up dual or triple therapy. This reduced the morbidity, mortality events by 40%. In the Triton study of initial triple versus dual therapy being macitentan and tadalafil plus or minus selexipag in newly diagnosed PAH, both arms reached the primary endpoint of improved PVR on right heart catheter by around 50%, with initial triple therapy reducing the first disease progression by 41% compared with dual therapy, again mostly driven by a difference in PAH-related hospitalizations. Overall mortality was reduced by 77% with initial triple combination therapy. Now, the treatment in these clinical trials wasn't modified according to the risk of disease progression or their likely outcome. The 2015 European Society of Cardiology and European Respiratory Society PH guidelines recommend risk assessment using a multidimensional stratification approach, with the aim being to maintain or bring patients into the lowest risk group. This stratification is based on modifiable clinical, functional, exercise, biochemical, echocardiographic, and hemodynamic variables with known prognostic significance, and patients are classified as low, intermediate, or high risk based on the expected one-year mortality. This is the pulmonary arterial hypertension treatment algorithm from the World Symposium of Pulmonary Hypertension in 2018. Note that it's recommended that all patients be referred to an expert centre for diagnosis and management of PAH, especially those with scleroderma, who are more difficult to assess and monitor than those patients with idiopathic PAH due to their comorbidities. Note that calcium channel blockers are not effective for scleroderma PAH, so vasodilator challenge is not required to be performed at right heart catheter in these patients. Initial therapy should be selected according to severity as assessed by the multiparametric risk stratification approach. Initial oral combination, even for low risk in addition to intermediate risk patients, is recommended, and the combination should include IV epoprostenol in the high-risk patients. The response to therapy should be assessed after 3 to 6 months, ideally with a repeat right heart catheter to enable more accurate risk stratification. Those still at intermediate or high risk should move to triple combination with either oral or IV prostacyclin analogues, and if there is no improvement, they should progress to maximal medical therapy with IV epoprostenol or even be considered for lung transplantation. Other models for calculating PAH risk scores include the REVEAL calculator, which uses a similar range of variables shown here. Less complex models simply count up the number of low-risk criteria fulfilled. In the case of the scleroderma PAH patients in this French PAH registry, you can, low-risk criteria were functional class, 6-minute walk distance, right atrial pressure, and cardiac index. You can see that the number of patients fulfilling an increasing number of low-risk criteria increased at the first follow-up. Survival is better in those with more low-risk criteria at baseline, shown in green. And interestingly, at follow-up, it's the risk stratification that is more strongly associated with outcome, shown in the right-hand panel, with the worst outcome in those patients who fail to fulfill any low-risk criteria after initial therapy, shown in red. The same applies in scleroderma PAH patients using the same set of low-risk criteria and the addition of NT-proBNP, based on baseline parameters, each with increasing hazard ratio for death at 1 year. with the highest all-cause mortality over 5 years being for those with the lowest numbers of low-risk criteria shown in blue. Using averaged risk at baseline as being either low, intermediate or high risk, again shows the worst survival for those with the highest risk in green, and that there's even greater divergence in all-cause mortality at the first follow-up according to the change in the risk category from baseline, namely the response to therapy. No improvement on follow-up had the worst outcome. Turning to the group of patients, scleroderma patients with group 3 pulmonary hypertension related to interstitial lung disease. These are the most challenging of all to diagnose, and they have the worst prognosis. Coexistent interstitial lung disease and pulmonary hypertension can be detected in anywhere between 8 and 18% of scleroderma patients, depending on the mode of detection. One might expect they'd in fact be easy to identify based on their reduced forced vital capacity, extensive parenchymal changes on high-resolution CT scan of the chest, and PAH hemodynamics on right heart catheter, although generally with a lower mean pulmonary artery pressure. But distinguishing between group 1 pulmonary hypertension with mild ILD, who really fit the true PAH category, versus group 3 pulmonary hypertension secondary to interstitial lung disease, and determining whether they should be treated with PAH-specific therapy can be challenging. This is due to the extreme variability and complexity in the relationship between interstitial lung disease severity and the development of pulmonary hypertension. Many patients fall between these two extremes and are more difficult to reliably classify as PAH or PAH interstitial lung disease. To date, PAH-specific therapy has been discouraged due to insufficient evidence of efficacy and safety. This is partly because most clinical trials of PAH have excluded patients with interstitial lung disease, and there's also a theoretical risk that vasodilators may worsen gas exchange by inhibiting hypoxic pulmonary vasoconstriction and exacerbating the ventilation perfusion mismatch. And this has certainly been seen with IV epoprostenol and riociguat. However, oral sildenafil can improve gas exchange through preferential pulmonary vasodilation in patients with severe lung fibrosis and secondary PAH, and looks like it is safe to use in these patients. Nonetheless, primary treatment approaches to date have tended to be limited to correcting hypoxemia using supplemental oxygen whenever appropriate and considering lung transplantation when not contraindicated by age or comorbidities. Prevention of progression of ILD with immunosuppressive therapies such as mycophenolate and antifibrotics such as nintedanib are also may have a place, but there's no evidence that these strategies can prevent or reverse progression to pulmonary hypertension. As a result, patients with scleroderma interstitial lung disease are often under-investigated for PAH as their symptoms of breathlessness and fatigue are erroneously attributed entirely to interstitial lung disease. This can delay treatment for PAH such that it is commenced when PAH is advanced and outcomes may be less favourable, or in some cases treatment may not be offered at all. Nonetheless, there's some evidence for intensive vasodilator therapy. Among 99 patients with scleroderma PAH, of whom nearly 3/4 had both PAH and ILD, all treated intensively with triple therapy regardless of severity of ILD, the 1 and 2 year transplant-free survival was nearly as good in the patients with ILD and PAH as in the isolated scleroderma PAH. Furthermore, the survival in the former group was significantly better than in historical controls, suggesting more intensive treatment may have been the reason for their better survival. Finally, don't underestimate the value of simple measures such as prevention of infection and correction of iron deficiency, as these may improve survival. In this slide, you can see that survival in the iron-deficient scleroderma PAH patients in red was worse than non-iron deficient patients with scleroderma PAH. In conclusion, scleroderma PAH is a complex disease that continues to have high morbidity and mortality. The right heart catheter and multidisciplinary assessment are essential to accurate diagnosis and treatment. There's increasing evidence that investigating patients with ILD for PAH is worthwhile. Combination therapy, being initial or sequential step-up therapy, is now considered the standard of care, with an aim being to the goal being to aim for a low-risk state. For high-risk patients, IV prostacyclin should be the treatment of choice, and sildenafil in ILD-PH at a minimum is probably indicated, if not more intensive therapy. For newly diagnosed patients with scleroderma, PAH, a multi-dimensional risk assessment is useful, particularly at follow-up, indicating the importance of early therapy and close monitoring, including right heart catheter, and be aware of general treatment measures for patients with PAH. Thank you for your attention.